We'll take a collective deep breath and welcome Dr. Rob Avery from Philadelphia for the no argument.
Tough to follow Andy's enthusiasm, but I will do my best. And I will take the no approach, and these are my disclosures. I do a lot of work in this area for multiple entities. And so let's reiterate the agreed upon facts between Dr. Lee and myself, that there is no data supporting screening. These are very good studies, but imperfect studies. And to answer the screening question, it would be cost prohibitive and probably unethical to some degree. We agree that if you have signs and symptoms, it is okay to go ahead and get that MRI. But a normal MRI doesn't say you're not going to have a tumor in the future. And really only a small number of patients with OPGs require treatment for there. So show me the data, Andy. Show me the data where we can make evidence rather than eminence-based decisions. So let's look at the old data or our current data. A small number of kids with gliomas need treatment. Let's put this in perspective. If you have NF1, that's a 1 in 3,000 disease. So you take 100 kids with NF1. Off the bat, 80% of them are not going to have gliomas, and you don't have to worry about 80% of those patients. Approximately 15 to 20% do have gliomas. But of those, at least 2/3 of them are not going to ever lose vision. So we don't need to, there's no treatment that's ever going to take place. And a small portion of them are going to experience vision loss and may require treatment. But let's look at the new data. Our small number of patients require treatment is, again, probably lower than we think. So I'm going to show you some recent data from the NF1 natural history study, which about 20 sites across the US and Australia are involved in, where we are prospectively evaluating kids with newly diagnosed NF1 OPGs. We've enrolled 116 of our goal of 250 subjects. I'm not going to tell you what percentage of subjects had their OPG discovered by screening MRI, but I will tell you it is an uncommon practice across the United States. I censored this data because I don't want to skew the data as it's being collected now and bias our investigators until the study is completed. And a small percentage of subjects were started on treatment after their initial diagnosis of an NF1 OPG. Andy says, hey, look, the visual assessment's hard in kids. We can't do this. I'm going to show you new data that we're pretty good at it if you live in our world. So here's data from the NF1 OPG natural history study, prospectively enrolled kids, that when we saw them at baseline, 85% of those kids could do teller acuity cards and give you a quantitative visual acuity. Almost half can do ATS HOTV. But we also want to know about the kids that are going to go on to treatment. 93% of those kids that were going to start treatment as part of this trial could do teller. That's pretty darn good for us. So we're better than we think, especially when we follow the guidelines to get quantitative acuity on these kids. Andy said MRI is the gold standard for the diagnosis. I will remind him that the road to hell is paved with good intentions, and that is not always the wise thing to do. We calculated just based on our data, if you screen, we will perform over 400 unnecessary MRIs with sedation for every 100 kids we see with OPGs. That is not insignificant, especially with the concern of sedation. We also don't consider the impact of finding incidental-omas. You find something that may be unnecessary or untreatable, but results in multiple MRIs downstream from that. So I also want you to remind you that there are guidelines out there. Don't miss the boat. Don't be a dinosaur and become extinct about that. The guidelines put out by Listernick, Ferner, Liu, and Gutman, and also reiterated in 2017, have clear guidelines of what you should do. We know if you should get an MRI when you can't obtain a quantitative acuity. Yes, there are those hard, difficult to examine toddlers, especially in NF, and if you can't prove their visual acuity is normal, get an MRI. If they have an abnormal eye exam, get an MRI. If they have monocular status, they have bad glaucoma in one eye, or they have a plexiform that is also causing vision loss in one eye, get an MRI. So as I tell my trainees, don't just do something, stand there, because usually help is on the way. Help is on the way to how to deal with this. And so in the era here, we've seen OCT now, and we've improved upon that with now using handheld OCT. And if you look around some of the exhibitors, we're moving into a new era of ultra-fast, 3 to 4 times imaging speed of our current generation. We're going to be able to readily image these toddlers much easier than we have before. We're also in the era of liquid tumor biopsies, where we're going to be able to stratify the risk of gliomas based on a blood sample rather than an MRI. And you couple that with artificial intelligence and machine learning, we're going to get there, but we're going to get there with data. Thank you.
Okay.